Hello, everyone. This is Braswell Dean from the Department of Family Medicine, and I am going to be sharing with you a lecture over metabolic syndrome. I'm really excited about this because I'm so interested in this particular field of medicine because we can help so many people. We'll jump right in. In the 1970s, the country came up with the food pyramid, and they were giving Americans guidelines to try to get healthier, to try to do better. And they were told to increase the amount of fresh, vegetables and fruits and grains and vegetable oils while trying to lower saturated fat intake into the diet. And we can see from these tables that Americans followed the advice. However, along the way, Americans have been getting fatter and fatter and sicker, and to the point where we've got a true epidemic now in diabetes and obesity in our country, despite all the dietary advice and the medicines that we have. We are spending about $30 billion. That's billion with a B. We're spending about $30 billion a month to take care of just diabetes, about almost $1 billion a day. And we don't have enough money in the whole world to take care of all these diabetics and unhealthy people. So we'll jump right in now to our office. What is the experience of the doctor on the ground, in the day-to-day, everyday office routine? Well, we'll jump right in and look at Olivia. She's 55 years old. She's pre-diabetic, and she's coming in with a history of hypertension. And we look and we see her weight is 382 pounds, okay, with a BMI of 59. And then we see that her total cholesterol is 209, triglycerides are 90, HDL cholesterol is 70, and LDL cholesterol is 121. She's got an A1C of 6.4, so it looks like she's a little on the pre-diabetic side. And so overall, and we have a TSH reflex of normal here. So what is your assessment of this patient's metabolic status? Well, since this talk is about metabolic syndrome, she probably has something metabolic wrong, right? So my goal for everyone first, that if you're listening to this, if you can remember what metabolic syndrome is, that'll be a good goal. And I kind of think about it if you look at your own hand. Just look at your hand. You got one thumb and four fingers. So the thumb, think about, corresponds to the HDL. It's the only thing that's low, okay? Just like your little finger's low. It's the smallest. So if you have low HDL, and then your index finger would be triglycerides, they're up. Your middle finger would be blood sugar, it's up. Blood pressure is on your ring finger, and weight is on your pinky finger. So you got four things up and one is down. And if you have 3 out of those 5 criteria, you've got metabolic syndrome, your patient does. So with Olivia, we have HDL and triglycerides are normal, but her blood sugar and her blood pressure and her weight are up. So she has metabolic syndrome. So you're probably asking yourself, okay, so what? I mean, do I really need to document that in the chart? Is that a new problem? Or could I just be satisfied with obesity, hypertension, and prediabetes on the chart? Well, metabolic syndrome does have clinical relevance. If I have all these together, I have something greater. And if we look at cardiovascular disease and correlate that to the metabolic syndrome, and we look at in patients over a period of time, we see that those people who have metabolic syndrome have higher risk of cardiovascular disease versus controls. And this trend continues, especially as time goes on. So it's our challenge as doctors, number one, to identify metabolic syndrome, and number two, to try to do something about metabolic syndrome as time goes on. We don't want to let people just exist in metabolic syndrome untreated without any interventions over time, because their risk of cardiovascular disease certainly goes up. Now, if we look at metabolic syndrome and look at the kind of risk factor cluster that comes with it, we now realize that, these are the things that we see all the time every day: hypertension, obesity. We're going to talk a little bit about hyperinsulinemia and how to look for that. But we see diabetes and prediabetes, and we sort of sometimes think about triglycerides a little bit, but really we tend to track cholesterol and LDL a little bit more. But this small, dense LDL, I mean, we're not used to thinking about what that is. And, LDL, HDL, we kind of think about that, and whether or not they're hypercoagulable or not. So these are things that we want to identify and explore a little bit on a deeper dive into this talk. Why? Because one big concept is that all of these things that project metabolic syndrome have a common denominator, and that is insulin resistance. Okay, so insulin resistance, you could call metabolic syndrome insulin resistance syndrome if you want to, because they're all variable presentations of a state of being hyperinsulinemic or insulin resistant. And this leads to the development of atherosclerosis and endothelial dysfunction. And we'll talk a little bit more about that, because this is a common denominator in mortality over here. All of these things affect endothelial cell health. Okay? And even to the point where more recently, a lot of the COVID patients being hypercoagulable and not know it were highly linked to diabetes and perhaps insulin resistance syndrome, metabolic syndrome. So we are going to continue to take a look at some of these cases, but we're going to do so with a frame of mind that hyperglycemia in diabetes is just one of the clinical features of the insulin resistance syndrome. So metabolic syndrome, it's associated with a whole bunch of other things, from neurological disorders like dementia. A lot of people call dementia diabetes type 3. It is so highly correlated. Polycystic ovarian syndrome, types of cancers, we'll touch on this a little bit, cardiovascular disease, type 2 diabetes, stroke, and non-alcoholic steatohepatitis. We'll talk a little bit about those things too. But in any event, we have a whole lot of things, as we've talked about, that contribute as risk factors to the development of insulin resistance. So I want to begin this talk. There's a Medscape review from 2002 that I thought was really good. And it's an interview with a couple of doctors, and one of the doctors was, during the interview, was saying, we want to take a look at this Get With the Guidelines program. It was a recent trial published in 2009, and they looked at over 200,000 patients who were admitted for ischemic cardiovascular events at hospitals all over the United States. Okay? So then from this population, they found about 136,000 of these patients had lipid assessments at the time of their events, of their cardiac events. Okay? And what was interesting is that these are the people who really represent cardiovascular disease today. But on average, the LDL cholesterol was only 105. Okay, so if you're a doctor out there, me and you, maybe primary doctors, and we're trying to prevent cardiovascular disease, we ought to be concerned about that, because if we're trying to prevent cardiovascular disease and you take a population like this, a significant amount of people, it kind of raises a flag that LDL-C didn't predict very well these events, okay? And what is interesting, that they did have low HDLs, okay? Their HDL-C was low at 40, but their triglycerides were over 161, okay? So HDL and triglycerides were out of whack, but we sort of train ourselves to look at the LDL, okay? They were all over, a lot of them were overweight, Many had high blood pressure. Okay, we think about those things. Okay, but it's really what the study found. It was, in terms of predictive value, it was a low HDL-C and high triglycerides that were really representing this group of people. And so when you look at this data, 160, almost 137,000 people admitted with confirmed acute coronary syndrome, and we look at the fact that just about half of them had LDLs under 100. And about a little over another half of them had problems with their HDL, okay? And we'll notice that the triglycerides were 161 on average. So the average LDL over here was 105. And so these are patients measured here, and it just goes to show you that in a graphic way that perhaps the LDL was not as helpful as we thought. So let's jump in and take a look now at the physiology of metabolic syndrome. And I didn't have a good enough slide prepared for you, so I just drew one out for you to go over the physiology of Met syndrome. So I want to look at Met syndrome in terms of what you can see and what you can measure, which is the standard lipid panel. But I want to make the point that the standard lipid panel that we were just talking about gives us so much more than just tracking LDL, okay? So let's take a look at some of the physiology of this from a standpoint that the lipids are really about energy, okay? There is your metabolic state requires energy. And so fat is one kind of a fuel and carbohydrates are another kind of a fuel. And so let's take a look at the fuel requirements from the vantage point of metabolic syndrome physiology. So up here in this diagram, this is your stomach, your GI tract, and you're eating fat. This is fat is coming into the body, and the body breaks the fat down into really basic components, called chylomicrons. Cholesterol can be absorbed, but the fat is absorbed as chylomicrons. Now the chylomicrons come in and they're dumped right into the portal system, and they bypass the liver, and this thing goes into the lymphatics from the portal system, and it gets dumped right into the circulation. Within minutes of you eating a meal and it's being absorbed, these chylomicrons are now in your circulation. So this is a very efficient way to bring energy supply into your body. And it goes to the tissues, like this is supposed to be muscle tissues. It can go to kidneys. And it deposits, and specifically the renal medulla is very high metabolism. So these chylomicrons, this instant energy, comes in and it feeds organ tissues. And those chylomicrons, these elemental fat gets deposited around the tissues as well. And these are called non-esterified fatty acids. Okay, and that is not the same thing as the fat in your body. Those are esterified into triglycerides, okay, with strings of glycerol fatty acids connected to a glycerol. Those are esterified. So these little non-esterified fatty acids here in the form of chylomicrons is sort of like analogous to where you get a package left at your doorstep from the Amazon driver. Okay, they leave a package at your doorstep. So in other words, we've got a little package of energy here in case you need it, and we give the muscle tissue instant energy if you're using it right away, but we deposit a little bit here just in case you need it. That's so efficient if you think about it. Now, anything that's left over and not used, the liver can use it to package it into its energy export-import system over here, and we're going to talk about that. And it can package fats for cholesterol synthesis as well. So even if you didn't have any cholesterol in your diet. Your liver would still make cholesterol. As a matter of fact, I believe the figure is something like 2/3 of the cholesterol in your body comes from the liver making the cholesterol. And that makes the point that cholesterol is so important to your body. And we sort of have been bred to think about cholesterol as a dangerous thing, but it's really, from a metabolic standpoint, it's very necessary. Cholesterol is the raw material of all tissues. Every tissue in your body has to have cholesterol. 60% of your brain is cholesterol, the cells in your brain. And cholesterol makes not only all tissues, but hormones in your body. And we'll look at that. Cholesterol has anti-inflammatory properties to it. And it's been said that cholesterol is life itself. If you're not making cholesterol, you won't live very long. Okay? So there's cholesterol coming in, and triglycerides are coming in as the instant energy in the form of the chylomicrons. Okay? And we talked about that. We talked about non-esterified fatty acids, and we talked about the liver's role in cholesterol synthesis. Then, the liver can then make decisions to package any extra energy in these elemental fat into triglycerides, and these elemental triglycerides are then packaged into VLDL apolipoproteins. You can think of these as boats that sail out into the oceans of your arteries and deliver, just like we were delivering over here with the chylomicrons. We're delivering these triglycerides, into esterified fatty acids into the tissue. So as the VLDL dumps a little bit of the triglyceride now to the body tissues, it reduces itself and it becomes, it shrinks a little bit. And from a VLDL now, we have an intermediate density lipoprotein. And when this goes around, it dumps its triglycerides to body tissues, and then it actually shrinks down to become what we see as LDL, low density lipoprotein. So this is a lipoprotein molecule. It has triglycerides in it, it has chylomicrons in it, and it has fat-soluble vitamins A, E, D, and K. Those vitamins are in there that have come in there, and they're getting distributed around the body as well. So this is what we've got here, this sort of a fat energy system, and it doesn't require a lot of insulin to bring this energy into the system. It's very efficient. Okay, now I'd like to pause right here and contrast this with a carbohydrate energy system. This requires insulin. So here's your gut again. You bring sugar in, and it's in the form of monosaccharides or polysaccharides as carbohydrates. It comes in, and it stimulates your beta cells in your pancreas to make insulin. Insulin is made, and it helps distribute these carbohydrates into the body tissues that use it. Okay, that's great. Now, anything left over from this system gets stored in your liver as glycogen, and then in between meals, the liver can release the glycogen back to glucose. Glycogenolysis occurs, and you've got glucose in your system. Okay, and the liver can, through gluconeogenesis, take other things such as proteins and other forms of amino acids and form glucose de novo. So having a little bit of glucose in the system is important, and the liver plays a big role in that. Now, one of the things of dysfunction occurs when you eat a whole bunch of carbs over years and years and years, and that requires more and more insulin to be made, and eventually the body, the tissues in the body can get resistant to so much of this as any other hormone, because insulin is a hormone. And so eventually what happens is the body has to make more and more insulin to get rid of the same amount of sugar, and we begin to have hyperinsulinemia. And eventually we have higher and higher levels of insulin, and we begin to have sugar left over in the bloodstream, so our sugar levels start going up, and we begin to start seeing pre-diabetes, and later, as more and more insulin has to be made, the body can't handle it, and there's more insulin resistance, and the patient begins to have type 2 diabetes. This is the physiology of type 2 diabetes. And over time, this hyperinsulinemia will cause the liver to be really packed in with glycogen. There's a lot of glycogen storage that has to occur. So, at this point, the liver begins to be begins to be insulin resistant as well. And when that happens, when the liver gets really resistant, it starts making some decisions. It says, you know what, we can't do this anymore because the liver's got to preserve itself. So it does a metabolic miracle. It changes this glycogen into triglyceride. Okay, so it's an energy conserving move here by the liver. The liver says, we've got too much energy, an energy excess. We've got to get rid of all this because we can't have all this extra glucose in the bloodstream. It's going to damage the kidneys and everything else. So we got to turn this extra glycogen into triglyceride, and that's what happens. So our energy import system that we were talking about last time, now not only is it loaded down with the cholesterol and the triglycerides, but it's now being loaded with even more triglycerides because the triglycerides are now being converted from the excess sugar, glycogen, and it gets dumped in to this VLDL system as well. So the body begins to make more and more VLDL molecules, or apolipoproteins. Okay. Now this is called the ApoB system. Apolipoprotein is like it's like a little zip code on these lipoproteins, and that tells the lipoprotein where to go. It's like we're going to put a stamp and a zip code on there, and then that's where it's like an Amazon truck. It knows where to go and deliver the package. So these VLDLs now, they float around the body and they go to where they're supposed to because they've got a zip code, and they dump their triglycerides and cholesterol at the tissues. But since right now we're just speaking about energy, I'm just focusing on triglycerides right now. So we dump the triglycerides at the tissue, and the VLDL shrinks down to IDL again, and the IDL goes to tissues, and it dumps its triglyceride load, and the IDL now becomes LDL. Okay, so low-density lipoprotein, just like the low-density lipoprotein over here. Now, the one problem with the high insulin state is that with higher and higher insulin states, insulin can begin to act as an oxidant to the LDL molecule, to the LDL lipoprotein. And normally, this is a large particle. But when it gets oxidized by insulin, it changes its size, and it becomes a damaged form of LDL. It's called small dense LDL. This is what damages your arterial wall, not this, and not this. And we will see a little bit later on more about this as well. Okay, so we're going to continue our journey for now. We'll leave the oxidized LDL over here, and we'll talk about that more later. But let's keep journeying with the LDL cholesterol. So what does it ultimately do? Well, the ultimate destination is fat. We've got to put this energy somewhere. We've distributed it to as many tissues as we can, but if there's still leftover energy, especially with all these extra triglycerides being formed, we got to put it somewhere. And the place that we put it is the energy reservoir called your visceral fat. This is what you see in your belly. Now, this is not the fat that you can like pinch an inch, like around your skin. This is the deep fat around your organs. You may have a lot of this even though you're a skinny person. Or you may have a lot of this if you're an obese person. Okay? So this is visceral fat. Visceral fat is under hormonal regulation. You know which hormone? Insulin. Insulin is a hormone. And we think of it as something made by the pancreas to regulate sugar, but insulin is a hormone made by the pancreas to regulate fat. It stimulates de novo lipogenesis. insulin is a fat storage hormone. So in other words, if you have high insulin, you're more likely to be obese. If you have high insulin, you're more likely to be one of these people who go to the gym 5 days a week and complain to the doctor, I can't lose a pound. That's because there's a hormone at play. That's because you're hyperinsulinemic. Okay? So, the fat stays around here. And until we need it. Now, sometimes we need it, and there's a connection over here. If the person is not at a high insulin state, in other words, if they're on a low carbohydrate diet, and they say, you know what, I've had enough of being fat, I want to reduce my carbohydrates, and all of this system begins to scale down, and I'm not putting extra triglycerides in my body, making them in the liver, bringing them into my body. And this goes down here. The body begins to use its visceral fat stores, and it breaks down the triglycerides into free fatty acids. There's a glycerol backbone, and there's fatty acids that come around. These were esterified fatty acids, okay? So they come around, they go to the liver, and the liver forms, depending on the metabolic state, the liver can change these fatty acids into ketones. And then these ketones can run the body just fine as well. They can cross the blood-brain barrier and do just great. So that's the sort of the physiology link between ketone formation when people are on lower carb diets. And this is how people, there's a completely different energy source. And so the visceral fat can be broken down into this elemental energy supply. It's sort of like an alternative energy supply. It's a cleaner energy because we don't have to worry about LDL oxidation. Okay, now, all of this triglyceride dumping into the system gets used, but we've got another system here, an apolipoproteinase system, and that is manifested by the HDL, the high-density lipoprotein molecule. So what does the HDL do? Think of this as sort of an energy conservation boat. It's like a tugboat. It picks up all the fragments. It picks up all the stragglers of triglycerides that aren't used by the tissues. It's always scavenging. Okay, do you have any leftovers? I'm going to take it and give it to another tissue that might need it. Or if nobody needs it, I'm going to take it back to the liver. And then the liver can take this triglyceride that's not used and put it back into another VLDL, and the whole system starts again. Isn't that beautiful? To me, this is just beautiful. And so we have a natural energy conservation system, and the liver can make the decision to take this and incorporate this into bile. Okay, so the HDL is picking up cholesterol that is not being used too, and when the HDL takes it back to the liver, it can secrete any extra cholesterol out as bile. So the liver can make cholesterol, the liver can excrete it. Isn't that cool? The liver can make glucose. The liver can get rid of glucose in terms of triglyceride. The liver can regenerate triglyceride into ketones. And I haven't gotten into it, but it can generate glucose straight out of protein too. So, but we won't go into that today. That'll be for another time. So HDL can take the extra cholesterol that's not been used, because remember we said cholesterol was the raw material and triglycerides are the energy. So leftover raw material, cholesterol, the HDL can take this to the adrenal glands to make hormones. It can redistribute cholesterol to other body tissues that might need it. And it conserves the triglycerides. Now, as it conserves all the extra triglycerides, and HDL is out here doing all this extra work, it has to work double time when there's so much more triglyceride in play because there's so much energy in play. The HDL gets consumed, gets used up, and can get damaged from extra insulin oxidation as well. So as a price that this system has to pay, it uses up its HDL to take care and clean up this energy system, okay? This is the ApoA system. And so there's an apolipoprotein A on this molecule, and it tells it where to go, and it has an address, ultimately taking it back to the liver. So it's like an energy export-import system. It's beautiful. And now, after all of this physiology review, sorry if it bored you, but it shows you the metabolic syndrome physiology. Why is HDL low? Because it gets consumed here. Why are triglycerides up? Because the liver's making it because of hyperinsulinemic state. Why is the sugar up? Because of excess carbohydrate consumption. And over time, we have insulin resistance, and we have a situation of beta cell burnout as well. Why is blood pressure up? Because insulin, believe it or not, has an aldosterone-like effect. It affects endothelial cell health, which is oxidation, which we'll talk about later, and it also has a direct effect on water metabolism, water absorption, just like aldosterone does. So hyperinsulinemia is very highly associated with hypertension. And why does the weight go up? Why? Well, insulin, we just said, was a fat storage hormone. So this is the physiology of metabolic syndrome. And just a couple of last points here. High insulin will oxidize large particle LDL to small dense LDL. So we'll talk about that, but this is a big point. It damages endothelial wall, and insulin has inflammatory properties to it. Okay? Lots of it. And it just goes to, just as an aside, it's even more pronounced when we're treating diabetics with insulin. The more we are injecting insulin, the more insulin resistant we're making them, and the more inflammatory problems we're causing in the long run. It's a downward spiral. And longer they're on insulin, the more and more over time they'll need. And another big point is, big concept we'll say, is cholesterol is just a molecule. There's no good cholesterol, there's no bad cholesterol. It's a beautiful molecule doing wonderful things around the body. You have to have cholesterol. LDL, it's just a lipoprotein. It's not anything. It's not the same thing as cholesterol. It is the lipoprotein that we're trying to measure, and we're trying to measure the lipoprotein to estimate the cholesterol. Okay, we'll talk a little bit more about that. Statins. We think about when we pull in statins to this conversation, we have to realize that we are inhibiting, we're trying to inhibit the production of cholesterol itself, liver production of cholesterol. And when we're doing that, we are interrupting this whole system to try to get to the LDL molecule over here. And we have to remember, and if you want to start a conversation or a controversy, start bringing up statins, because so many different people have so many different opinions on this. And without getting too deep in the woods, let's just say that cholesterol has a role to play in the body. And if you start inhibiting its production, you will have many consequences there. Statins do affect the brain. They cause mild cognitive impairment as a side effect. We have to be aware of these things as doctors. They can cause liver damage, liver irritation, muscle irritation, joint problems. And again, statins will affect LDL large particle production. In other words, the healthy cholesterol gets lowered, as well as the HDL. This is your protective lipoprotein over here. And so when you start reducing HDL, you can affect hormone production as well. Okay, so we'll get into this a little bit more. LDL, this is LDL, this is the LDL-C, okay? So the LDL, again, just to make the point that this is an apolipoprotein, and the apolipoprotein B is a part of the protein that just is like, think of it as in a zip code. It's got a region that it goes to, and it's made up of free cholesterol. It's made up of a phospholipid bilayer here. It's made up of esterified cholesterol and triglycerides here. So it's all in a package here, okay? And then the LDL-C is kind of what we're trying to estimate the amount of cholesterol within the LDL. This is the lipoprotein. So when we think of LDL, we're not really talking about cholesterol. We're talking about a lipoprotein molecule. And the LDL-C that we all, have learned to either fear or track or whatever, this is what it is. It's just it's a surrogate marker, and we've been using it since around 1972, okay, to try to estimate the cholesterol contained within the lipoprotein molecule. Here's the cholesterol molecule. Notice that it's a molecule. It's an organic molecule. There's no good cholesterol. There's no bad cholesterol. Those are just terminologies that, from a very oversimplified way of trying to look at things. And cholesterol has many, many roles. And, without cholesterol, you don't have any vital hormones for life, not to mention tissues of the body. And in cholesterol synthesis, it occurs from mevalonic acid. The statins inhibit this step here, so we don't have cholesterol formed from mevalonic acid. So in other words, that does affect cellular repair, hormone synthesis, and it does affect this energy transport passenger. Cholesterol basically is a passenger in the energy transport system that we've been talking about. But a couple of other things that we don't think about sometimes is that the statins also inhibit coenzyme Q10 formation. Ubiquinone is the active form of CoQ10. CoQ10 is an antioxidant around the body. It also works for muscle contraction. The muscle that uses CoQ10 the most in the body is the heart muscle. It just soaks it up like a sponge. So a lot of these folks on statins, if our cardiology friends insist that the patient has to be on a statin, one thing I try to talk to my patients about is at least try to take a supplement of CoQ10, because your body, the statin is inhibiting your body from making this. CoQ10 is important for mitochondrial electron transport, and it is important in a lot of things that start with the letter M. Your mood, mind or memory, oral health, mouth, muscles, muscle contraction, and myocardium. So all those things are important with CoQ10, that CoQ10 contributes to. And then this other molecule that we never think about is dolicol. It's an antioxidant, and it's a protectant. It serves to possibly protect lipids. And a lot of people have been doing research lately into the fact that this does have protection from types of cancer growths, because there are some research going into that, and into the the risk for oxidation in terms of how cancers can start. So again, there's nothing in this pathway that's evil. All cholesterol has been doing is repairing and making things. Cholesterol is a raw material for so many good things in the body. So really, there's no good cholesterol, there's no bad cholesterol. Cholesterol doesn't turn evil at any certain point. It's there to repair tissues. Now, HDL, just a quick word on HDL. We could go on and on for this, but just in summary, HDL is there to ferry cholesterol and triglycerides back and forth from the VLDLs. If there's any excess, it can take it to the adrenal cortex and gonads for hormonal synthesis. It can take used or leftover cholesterol from the LDL system and ferry it all back to the liver for reprocessing or excretion into the gut, as we talked about earlier. Tissues, leftover stuff gets HDL, and also from the macrophages and the foam cells that eventually set up shop in arterial cell walls. Cholesterol is deposited there to repair damaged arterial cell walls. Anything left over is taken up by HDL and redistributed for conservation. We'll talk a little bit more about this as well. A quick mnemonic: side effects of statins for the HMG-CoA inhibitors. I just think about HMG-CoA. Hepatotoxicity, we look for the AST and ALTs. Myopathies, myalgias, myositis, and rhabdomyolysis. The G for glucose, obviously. Did you know? I mean, we don't think about it, but one of the side effects of statins is diabetes, believe it or not. So it can make folks prone for that. So it's almost like, really? So we have GI symptoms: nausea, vomiting, diarrhea. And then the C is cognitive impairment. Mild cognitive impairment is a side effect of statins that we have to be watching for, especially in our elderly patients. So be aware of that. Cataracts as well, and arthralgias. I think I've seen my fair share of hepatotoxicity. Usually the AST-ALT elevation, as long as it's below 90 or below 100, I think most people just, if they have to be on statins, will watch it. For me, I'm more and more thinking that this is going to have to be at least maybe a conversation with the cardiologist to talk about whether or not there's a risk benefit here. And we'll talk a little bit more in this talk about how to get to that point. A lot of myopathies and cognitive impairment is out there as well. We have to be really well aware of that. What are PCSK9 inhibitors? I just couldn't resist. I call them canines because it's easier than saying PCSK9s over and over. But these little canines are like dogs. They're like little dogs that want to come over here to the LDL receptors on the liver and chew them up. And if you chew up all the LDL receptors, theoretically, there's more LDL that can't come back and dock at, the harbor here. And so basically these K9 inhibitors inhibit the PCSK9s here. And so because we're inhibiting these little dogs from chewing up the receptors are preserved and more HDL can dock. And then that's how supposedly the K9 inhibitors lower the LDL concentration. Now, whether or not that's the primary objective or not, that's a whole nother story. I'm just showing you how they work so you can kind of keep it in the back of your mind. But that's how they work. Here's another study that if this talk, we haven't gotten into it, now let's mix it up a little bit and see what we're talking about whether or not we would want to use a K9 inhibitor or not. Well, here's a study that looks at hyperinsulinemia as a predictor of new cardiovascular events in Colombian patients who've had a first myocardial infarction. Okay, and it's from April 2011. So they looked at 295 patients who survived their first MI. Okay, and they looked at these people between 2000 and 2006. Okay, so they looked at lipids, they looked at glucose, they looked at plasma insulin levels, okay, everything we've just been talking about. And then they talked about new cardiovascular events, either death or a new MI, unstable angina, heart failure, stroke, or whether they had to have some type of revascularization or angioplasty. Okay, so they took a look basically at a whole bunch of people and followed them in terms of in terms of these things that we've just been talking about. Okay. So about 38% had new events. Okay. They had more stuff happen to them. And almost 20% of them were diabetic, by the way. And so they did a bivariate analysis first to try to find some risk factors, okay? And they took a look at the contributing risk factors, being hypertension or anterior descending coronary artery stenosis or cardiac failure, age, low income, lack of education, heart rate class of heart failure, heart rate over 76, pulse pressure over 80, total cholesterol over 200. I'm not sure how over 76 would be significant, but that's what they measured. Total cholesterol over 200. Okay, there's our cholesterol buddy. And insulin over 10. And then what they did is to try to find out the impact, the true impact of these variables. They did a logistic regression analysis, which is supposed to like drill down to really not have any confounding variable on the variable you're trying to measure. Okay. And then they found insulin remained the only significant predictor for new cardiovascular events. And that really should blow your mind. Hyperinsulinemia was the most important factor associated with the occurrence of a new cardiovascular event. Okay? How many times are we checking that? Or do we think about the impact that insulin is playing? Now, we just got through saying that metabolic syndrome is all about hyperinsulinemia. Okay, so keep that in your mind as we go forward. But this should be bringing to light a little bit the role of insulin resistance in the pathophysiologic mechanisms of the atherosclerosis. Okay, we were talking about oxidation in LDL molecules and oxidation in arterial cell walls. We're going to be talking about that too. I just thought this was a nice intro for that. This is sort of some of the summaries of this, okay? And so when you look at the impact of hypertension, diastolic blood pressure, total cholesterol, LDL cholesterol, and you look at the risk ratios, okay? And you're comparing the risk ratios to a value of 1, okay? If it equals 1, there's no association with disease. And if it's over 1, there seems to be a positive relationship to disease. But it's not until you're supposed to get like 1.5 that it's really beginning to be significant. So when you look at these variables, hypertension has the best variable for predicting another cardiac event, right? You say, wow, okay, that's why we're always measuring the blood pressure in the heart patients. Make sure they take their lisinopril and all this other stuff. Maybe the diastolic pressure, we're watching them too. But they then did a multivariate analysis. They were trying to see if there's any confounders to these risk ratios, okay? And what they found was, despite all this, in the multivariate analysis, nothing came close to insulin. Nothing came close to insulin. Okay, so now, here's another study. This was from the American Journal of Cardiology, and it was a Chinese study, and they looked at the efficacy of cholesterol levels and ratios predicting future coronary heart disease events, okay? Kind of another thing. And this study tracked 3,000 people over 8 years, okay? An even bigger study. And they looked at the hazard ratios to show the relative risk of disease, okay? Now, hazard ratio over 2 is acknowledged as being significant. Okay, so we're looking at hazard ratios. Okay, so what they found is whether or not you had a low LDL cholesterol or whether or not you had a high LDL cholesterol. The only thing that predicted future coronary events over this 8-year period of time was the total cholesterol ratio over HDL ratio. If it was elevated, okay, there was prediction, there was a significant predictability of coronary events, independent of the LDL. If the total cholesterol HDL ratio was less than 5, it was protective, independent of the LDL cholesterol. Okay? So this shows you that the total cholesterol HDL ratio predicts just about all the risk, regardless of the LDL. It's irrelevant. And we've got to ask ourselves, LDL is just a lipoprotein doing its job. It's just transporting triglycerides and cholesterol to and from the body. Okay? So there's got to be something more. There's got to be something more going on. And we're making the point that it's the insulin, not this little lipoprotein here. Okay, let's look at another study from 2015, a little bit more recent too. And it was a study of the use of lipid panels as a marker of insulin resistance to determine cardiovascular risk. Okay, right up our alley in metabolic medicine here. So this study was another big study that tracked 103,646 patients. They're aged about 50 to 75 years old for 8 years. Okay, another big study. One group was a low group where the LDL was less than 140, and another had a high group, over 140. Okay, so 13% of the low LDL people got heart disease, and 14% in the high LDL got it. So it really didn't matter. About the same amount of people got heart disease in the low versus the high LDL. Okay, so LDL really did not help the doctors there trying to figure out who was going to get heart disease and who wasn't. Okay, whether you're low, whether you're high, you're going to get it. I'm sure people made the case for statins or no statins or whatever, but tracking LDL cholesterol didn't help anybody. Okay, so in this study, the thing that did show predictability was HDL. It was more powerful again. It outperformed the LDL. And something even stronger than HDL in this study was the triglyceride HDL ratio. And if you had a low triglyceride HDL ratio, you had a 9.2% risk. If you had a high triglyceride HDL ratio, you had an 18.5% risk, twice as many people. And that's a significant predictor. These are significant predictors. And so as we studied the triglyceride HDL ratio, if you have a whole bunch of triglycerides, remember we said the liver's making excess triglycerides due to hyperinsulinemia, putting them out in the VLDL molecule, and then after that the HDL molecule gets consumed when they're trying to take up the scavengers, trying to take up the leftovers. That is what we see in metabolic syndrome due to insulin resistance. Okay? So it's the ratio of these lipid proteins that is more powerful in a predictor than just tracking LDL cholesterol. So this is looking at the data a different way from Ivor Cummins. He put this together. And it goes to show you that about the same amount of people had heart attacks in the people who had low LDL versus the high LDL group. Okay? Didn't, maybe 1% point difference. Didn't really give you much to talk to the patient about if you're just tracking LDL. But if you're over here looking at triglyceride HDL ratio, and if you have a high ratio, you are almost 20 times, you're like a 20% risk of having a second coronary event compared to the people who had triglyceride HDL ratios that were low. Okay? So the low triglyceride implies that the liver's not making as many triglycerides because of hyperinsulinemia, and there's more HDL left over, so that would make this ratio low, less insulin resistance. Okay, so if we're trying to assess the metabolic health of a patient, these studies are saying we should pay attention to the triglyceride HDL ratios or some of these ratios rather than just going after LDL-C. It makes physiologic sense when you understand the physiology. I couldn't resist. This is called an NMR test. It's an advanced lipid test. And this is really the state of the art right now, because the standard lipid panel, which is what we're doing right now, this came about in the 1970s. But now we can measure the amount of small LDL particles. We can measure the amount of large HDL particles. We can measure the amount of VLDLs out there. We can measure the HDL particles, number and size. We can do all those things. And so in this measurement here, this actually is my measurement. I did this on myself so I could show you guys. LDL particle number is pretty low. We want a low thing because it implies if I don't have as many LDL particles out there, that means I'm not dealing with, that energy overload state where I have to make a whole bunch extra. So it's a nice low number. And the small LDL particle number is good because I don't want small, dense LDL. If this was high over here, that would mean there's a lot of oxidation of large particle LDL into small, dense LDL. Okay, and that would be representative of hyperinsulinemia, and I don't want that. So we can measure, and if you've got patients and you're not quite sure if they should be on a statin or not, and you're trying to figure out, what their true lipid looks like, you can always run an NMR if you want to talk to the patient. I can't predict coverage on that, but it does drill down to know exactly what's going on with the patient. So NMR. Okay, now let's take a look at a patient in the office. This is Leonard. He comes in. He's a 71-year-old male, and he says, I'm not too shabby. I don't feel too bad. So let's take a look and see what our metabolic assessment of him might be. A1C 5.6, fasting glucose 8.5, total cholesterol 147, triglycerides 98, HDL 56, LDL 71. Not too bad, right? Well, he's 290 pounds with a BMI of 40, okay? So that's kind of significant. He's got hypertension. He's morbidly obese. He's on atorvastatin. He's on lisinopril. What's your assessment? Well, it looks like he's doing okay. He needs to lose a little weight, watch his blood pressure, maybe take his medicines, work on the lifestyle changes. Your assessment, maybe not too shabby. Should we do any other tests? Well, I got a fasting insulin level on him because I was suspecting maybe a little metabolic syndrome. His glucose fasting was 85. So we calculated a HOMA score, or a HOMA IR, and that equals 8. And anything over 2 suggests insulin resistance. Okay, so what does that mean in terms of metabolic assessment? Well, first off, remember, we've been making the point that it's all about the insulin. The glucose is just a variable. It's just a symptom like fever. The real driver of cardiovascular risk is insulin. The real driver of metabolic syndrome is hyperinsulinemia. Okay, so let's take a look. What the heck is the HOMA score, and how can you use it? How can this be really easy to use in your practice? Well, a HOMA IR score is calculated as glucose times insulin, fasting glucose over fasting insulin, times 405 if you're using the system here in the United States with milligrams per deciliter, and it's glucose times insulin fasting over 22.5 if you're in molar units, like millimoles per liter. So it's trying to make the point that you can't put all your eggs in the basket of just glucose. And so it's trying to make the point that the patient can have a fasting insulin of 86, but if they have a fasting insulin of 16, their HOMA IR score is over 2. That implies insulin resistance, even though they come in with a pretty good-looking glucose. On the other hand, another patient could come in with a fasting glucose of 100. You go, I'm worried about you. But if the fasting insulin is only 4, the HOMA IR is around 1. So the person metabolically who comes in with the glucose of 100 is actually better in terms of his insulin resistance status than the person who comes in with a fasting glucose of 86, because his or her HOMA score is in the insulin resistant category. Okay, so with Leonard's situation, his fasting glucose was 85. That looked pretty good, but his insulin was sky high. And the reason I was sort of suspecting that, he was so heavy. Remember, insulin is a fat storage hormone. You can look at people sometimes, if they're really, really overweight, morbidly obese, they almost all have hyperinsulinemia. They're almost all insulin resistant. Okay? His HOMA score was 8. So what did we do? He started off at 339 pounds, and we put him on a low-carbohydrate diet. We tried to reverse some of this excess insulin, okay? This happened during COVID, and he lost 70 pounds. So remember, low carbohydrate intake means lower insulin, and lower insulin allows weight loss because insulin is a fat storage hormone. And if we lower insulin, we're lowering cardiovascular risk because we're lowering metabolic syndrome. Any other tests for Leonard? Well, we did. We got something called a CAC scan, which is a coronary artery calcium scan. Okay? Why? Because he was at high risk for cardiovascular problems. And his total calcium score was 756. And then we got another one a little bit later, and it increased to 949. And remember, all of this is with an LDL-C of 71. Okay? So in analysis, he had an initial CAC of 756 and then another one of 949. Our goal is to have a less than 15% increase per year because that would be slow plaque growth. His jumped 26%. So what we have to do is, some intensive lifestyle modifications to try to prevent heart disease, a cardiac event. So what is the CAC score? What is a calcium heart scan? It basically is a CAT scan of the heart, sort of like a mammogram is of the breast. It looks at the disease. And this is a study, this is sort of a summary for the study, just for the sake of brevity, that it looked at a whole bunch of people with Framingham scores, and all of the Framingham people had cardiac risk of 10% based on risk factors. Because remember, Framingham is just a calculation. And basically, they compared CACs with these people over the years, and basically the people who had 10% risk, a lot of these people had scores over 600, and some of these people had no risk. And some of these people, it did fairly correlate with, but again, the Framingham risk did not correlate with the outcomes in these folks. And so basically, this is trying to illustrate that the relevance here for the heart scan shows you the disease. When you try to use risk calculators, you're just trying to calculate risk. This is the Framingham score risk calculator. This is called the MESA risk calculator. This is called the AstroCharm risk calculator. There's an ASCVD calculator. All of these calculators calculate risk. But this is a summary slide of there have been a lot of studies comparing the CAC scan to risk calculators, or calculating coronary risk or coronary 10-year mortality rates based on risk calculations. And every instance in every one of these studies, and there's other studies too, but just the bottom line is it's trying to make a point here that the CAC is a very, very validated and powerful screening tool for cardiac risk. Okay. we'll leave it at that. And we're going to now just make the point that if you want to use ratios, either cholesterol to HDL or triglyceride to HDL, my favorite is triglyceride to HDL because it just makes so much sense to me physiologically. The ratios always outperform LDL-C in predicting cardiac risk. Okay? So CAC outperforms them all, but if you don't have a CAC scan, use a ratio. Here's another one. This is a study of the Heinz-Nixdorf study from 2014. They followed over 4,000 people over 5 years, and they tried to correlate the LDL with the patients with their CACs worsening. And so over time, you can see the CACs patients slowly worsening, but the LDL cholesterol had no correlation between those with low CACs and those with high CACs. It's all about the same. Okay? So really where the money is CAC is actually measuring the growth of plaque, where LDL-C, you can't trust it. There's a really good film I would encourage you guys to look at. It's called The Widowmaker. You can find it free on Amazon. It will really tell you the story of the CAC scan. I think you should watch it. And I routinely give this movie to patients to take a look at so that they can be informed more about this scan. One of the things when patients come in and talk about the CAC scan, I'll talk about that it is a predictor. And these are the risk profiles that we just talked about of what the score actually means in terms of this comes from validated studies. This is not a calculated risk. This is a measured risk and outcome. So we talk about this, and a lot of people say with a high score, they're going to be really concerned if, like Leonard was, if his score is really high. But the thing that gives people hope, I think, is when you look at the progression of the plaque and actually who dies. Myocardial events who have a CAC risk of less than 15% per year, or a CAC, or those getting MIs with a CAC increase of over 15% per year. And so as you can see, if you're growing plaque at a slow rate of growth, less than 15% a year, your plaque is pretty stable. And so that risk now drops to 3%. And it doesn't matter if your score is low or score is really, really high. That plaque growth is going to be, if it's low, your risk for MI is really low too. But let's say if you have a little bit of plaque, but if you're growing plaque at a high rate, then your risk can jump to 20% here, or it can be over 50% if you've got a lot of plaque and you're growing a lot of plaque really, really fast. So it's been said that the only thing more valuable than the first CAC scan is the second one. And this is the perspective of the second CAC scan. Okay? So if I've got a patient who has a lot of plaque burden, I definitely want to get another CAC in a year, but I want to do some things to try to minimize the rate of plaque growth. And the interventions, now this is sort of a summary of some of the interventions that people are using. Most everybody's going to be on atorvastatin. I think that's most everybody. But I'll usually talk to the patients, and I'll usually make a cardiology referral just, to let the cardiologist be on board. It's kind of a good thing to do, I think. And they're almost always going to want to start people on atorvastatin or something like that. But beyond that, and if patients really have strong reservations about not doing that, like some people have some mild cognitive impairment, some people cannot tolerate the statin, some people have liver disease already, or some people are suffering from arthritis or some other things. So there's a lot of issues to go into this. And the efficacy of statin use is a whole other talk, but I usually start here and tell people that exercise is tolerated. But the foundation, the cornerstone of this is, is to try to address the thing that is driving metabolic syndrome, and that's a low carbohydrate diet. Okay, magnesium has been shown to have an anti-inflammatory property and relaxes arterial smooth muscles as well. It's what you give people who are coding, right? Omega-3 fatty acids in really high doses have been shown to have an anti-inflammatory property too. There's been some studies that bring it in at lower doses that say it doesn't do anything, but they're really, they do a disservice, because the higher doses have been the studies that have been published that are significant, and they're just hard to do sometimes, hard to do these kind of studies in nutrition. But in any event, these are the things that are published out there. Vitamin D, people are using 5,000 international units a day of vitamin D or something like that, but vitamin D has been shown to also have an anti-inflammatory property to it. So vitamin K2, an interesting vitamin. If your vitamin K2 levels are low, the calcium that you eat in your diet is going to end up in your arteries. But if your vitamin K2 is adequate, then the calcium that you eat in your diet will go into your bones. So most people would advocate taking vitamin K2 also, so that we keep calcium out of the arteries. And then we'd follow up with a CAC scan in a year to verify the plaque growth is low. So has anybody ever been able to reduce the plaque formation? I've had one patient where we have actually done intervention and the plaque got better. But in general, I think of the plaque as sort of a permanent thing, and we try to slow plaque growth. So let's talk just for a second about the endothelial damage that occurs from insulin and the glucose spike. So when you eat glucose and the glucose comes in, it creates insulin. Okay, an insulin spike has to occur, and this insulin produces an oxidative stress on the endothelial cells, the endothelial lining. Just like we said, it produces an oxidative stress on LDL large particle, and it oxidizes it into small, dense LDL. Okay? So you think about waves crashing into this wall. Breakfast, boom. Lunch, boom. Dinner time, boom. And depending on the carbohydrate concentration, or the amount of sugar that you're eating in your diet, if you're eating a high carb intake, breakfast, lunch, and dinner, the body is having to spike insulin, okay, all during the day, and we're having endothelial dysfunction here. And it shocks tissue glycocalyx, which is a protective lining in the endothelium, okay? And that exposure is what causes the endothelial dysfunction, atherosclerosis, and the cardiovascular events that we said at the very beginning of this presentation, that's metabolic syndrome. That's the sort of the final straw. Let's take a look. The endothelium is made up of this thing called tissue glycocalyx. They're a very fine, hairy-like substance here that protect the endothelial cell and the subendothelial layers. And this hairy-like substance sort of protects from coagulation, okay? And remember we said that hyperinsulinemic patients can be more prone to hypercoagulable states? Well, that's because they have more damage to tissue glycocalyx, and then they're more prone to hypercoagulable states. But this tissue glycocalyx is real slippery. If you've ever picked up a fish, like when you went fishing, and they're real slippery, fish on the outside of their scales, they have tissue glycocalyx. They have glycocalyx, the same kind of thing. And that's what makes the fish slippery. That's what makes your arterial lining really slippery. Okay? So blood you can have laminar blood flow across this. Now here is the effect of a high-carb meal on tissue glycocalyx. The normal glycocalyx here, this is 2 hours, 4 hours, and 6 hours after a high-carb meal with high insulin exposure. Okay? So you can see what insulin does to tissue glycocalyx 6 hours after the high-carb meal. And if then after that 6 hours you're eating another high-carb meal and another one, you know, you're really damaging tissue glycocalyx over and over. And this sets up shop for arterial dysfunction. So what happens when the tissue glycocalyx gets damaged? Well, when it gets damaged, the LDL molecule gets oxidized by insulin, and then it comes in, and then this oxidized LDL particle, okay, gets exposed to the endothelium, and then either through penocytosis or leaky endothelial cell walls, this oxidized, small, dense LDL makes its way into the subendothelial layer. And that's what sets up the inflammatory reaction in the arterial cell wall, that you have tissue macrophages coming into the area and forming foam cells. Okay? And then, of course, cholesterol comes into the area to repair cell walls. That's why cholesterol is always, they're always worried about cholesterol, but it comes in to repair. But this is the inflammatory reaction that gets set up. The foam cells get set up. And this is, and then as the body reacts to the inflammation, the body starts putting calcium down in this arterial wall. Damaged tissue glycocalyx makes it more prone for platelets to form and clot blood, and you have clotting problems. This is also one of the proposed mechanisms of action in the lungs of the people who are having metabolic syndrome risk, why some people are more prone than others to having blood clots when exposed to coronavirus. Let's take a look at a physical exam person now. So we've made a lot of points about metabolic syndrome and what it does. Now let's take another look. Case number 2, 52-year-old male comes in for a physical exam. Everything looks good so far. The CBC looks pretty good. Platelets look great. All right. An A1C of 6, fasting glucose 137, total cholesterol 179. So, is the person diabetic? Well, this number looks, yes, this number looks more like pre-diabetes. Okay. So, pre-diabetes versus diabetes. All right. Kind of know what's going on so far. But look at the triglycerides. My goodness, 556. HDL really low at 29. And based on what we've said so far, you're thinking maybe metabolic syndrome here, right? And look at the LDL. It's doing its thing. Okay. But if we calculate the triglyceride HDL ratio, it's 19. Our goal is less than 2. And so a quick calculation here tells us that, this is a risk. This is cardiac risk, So something's up. And it's more powerful predictor of cardiac risk than trying to look at LDL. Okay? Fasting insulin, 136. This person definitely is hyperinsulinemic, right? The HOMA score, because remember we got a fasting glucose here, all right? Sorry to be jumping around here. There's my fasting glucose. And so from that fasting glucose and the fasting insulin, I calculate a HOMA score. And that score, if it's over 2, is insulin resistance, and his is 46. So he is definitely insulin resistant with metabolic syndrome. So it just goes to show you that measuring blood glucose is only an indirect measurement of the disease processes occurring here. It's really about the insulin. Insulin resistance syndrome is metabolic syndrome. Whether or not this person is diabetic or pre-diabetic, it really doesn't matter. And I put this one in here because the A1C was looking reassured, and then the fasting glucose is a little on the diabetic range. And we can sort of chase our tail on this over and over. But we want to, if we look at these things, especially like a triglyceride HDL ratio and the HOMA score, we can zero in on who has cardiac risk and what's going on metabolically, okay? So again, our HDL, triglycerides, and blood sugar were abnormal. LDL really hasn't helped us all that much. Here's another person coming in, African-American male, for routine physical exam. He's on atorvastatin, okay? And I calculated, this was back in the day, I calculated an ASCVD risk of 28 and think, whoa, okay, maybe we need to do something. His triglyceride HDL ratio was 2.7, okay, so that implies cardiac risk. A HOMA score is over 2.4, I mean it's 2.4, it's over 2, so that implies insulin resistance. Okay, but when we look, he had a normal LDL cholesterol, and his total cholesterol is 116. He's on atorvastatin. So what would you do? Keep taking your medicines, right? I advised him to get a CAC scan. I wanted to see if there was more plaque. I wanted to see what was under the hood, so to speak. I wanted to see if there was more cardiac risk than we were measuring, because this says he's got 28% cardiac risk. Let's measure it and let's see if this is true or not. Okay, there's our low HDL and our triglycerides. They're both kind of low, but remember, atorvastatin is suppressing both of them. So let's take a quick look at his numbers, probably 7 years that I was tracking his numbers, okay? His LDL cholesterol has been beautiful, 66 to 65. His highest one probably was 97. He's been on atorvastatin all this time with beautiful LDLs, right? But he had his MI on 3/20/20. Despite all of this, despite the atorvastatin, and despite beautiful LDL control, he has his MI. He never did get a CAC. And this is when I started the atorvastatin until the time of his heart attack. ST elevated MI, total occlusion of the distal LAD. LDL-C was irrelevant. Case number 4, hyperlipidemia, follow-up visit. This person comes in, triglycerides 268, HDL 33. Look at that. He's watching his cholesterol on a low-fat diet. He's on atorvastatin. I mean, his LDL has been suppressed down to 7. Cholesterol has been suppressed down to 94. So, on one hand, we might feel good about ourselves that the LDL is super low, right? He's on atorvastatin. If you calculate the ASCVD, it's 43% risk. This person, I got a CAC, it was 297. That's 16% 10-year risk. So notice that the CAC can sometimes correct the ASCVD and bring it down. 30% of cases it will correct. And it shows you that this is not as accurate as this is. A1C 7.5, pre-diabetic, right? Or no, I'm sorry, he's in diabetic range. And triglyceride HDL is 8. So he's eating a low-fat diet. Where's all this triglyceride coming from? I mean, he's not eating whale blubber, right? Where's it all coming from? Oops. Well, we know that it's coming from the hyperinsulinemia. The liver is making excess triglycerides, right? This is metabolic syndrome. Case number 5, this is another just quick case for you. This person's coming in to follow up pre-diabetes. The diabetes is getting better. Okay, 5.6, but look at his triglycerides. 252. Non-HDL cholesterol, 207. And HDL is only 38. Okay? So if the pre-diabetes is better, why are the triglycerides so high? Well, you can't go by blood sugar, remember? We want to think about the insulin. So when we look at fasting glucose and fasting insulin, 45 here, we calculate a HOMA score of 12. He's very hyperinsulinemic. So even though the A1C is getting better, we want to be measuring the HOMA to see if the HOMA is getting better. Okay? Because it's metabolic syndrome is driven by the insulin resistance. It's the blood sugar is just sort of a symptom. It's a variable. And it's the hyperinsulinemia that is driving the triglycerides. And then another question is, what does the non-HDL cholesterol represent? I mean, we know it's not the LDL and the HDL. What is it? And it's not the VLDL. Well, it's the VLDL. That's what it is. So that means the liver is making so much triglyceride, it's having to make a lot of VLDL, apolipoprotein boats, and this is the excess boats that the liver is making to put the triglyceride in. So this system, this energy system is really overloaded. There's so much energy coming into the liver. The liver's trying to get rid of it all. And I forgot to mention back on the slide earlier, when the liver is having to make so much triglyceride in the liver, that's where you can start having a liver with fatty liver disease, non-alcoholic fatty liver disease. The weight's high. Why? Morbidly obese. That's hyperinsulinemia driving the obesity. Let's look at a few studies to conclude this talk. American Journal of Cardiology just came out last year in 2020, Saturated Fats and Health, a reassessment and proposal for food-based recommendations. It was a meta-analysis of about 400,000 people of randomized controlled trials and found no significant evidence for saturated fat on cardiac disease. How about that? And it says in the highlights basically that historically the guidelines, U.S. dietary guidelines, say to restrict saturated fatty acids. But they're basically saying now there's no robust evidence that current population-wide arbitrary upper limits on saturated fat consumption in the United States will prevent cardiovascular disease or reduce mortality. This is a big deal. And it should be, on our radar as primary doctors for sure. Because chasing LDL is not what it's all about. And saturated fat is a healthy fat. And there's still a lot of debate right now in nutritional science, but this is a really important study. And I just wanted to read this to you. Although saturated fat increases LDL, everybody and their brother will quote that, oh, the LDL went up, okay, in most individuals. This is not due to increasing levels of small, dense LDL particles, but rather the large LDL particles, which are much less strongly related to cardiovascular risk. In other words, a lot of these other studies in the past keep saying, well, if you eat saturated fatty acid, your LDL goes up, and that causes, that's a bad predictor of heart disease. And what is happening now as the research continues to come in is that LDL is not a good predictor of cardiovascular disease mortality. It's really not. And the thing that we are now learning, instead of depending on the testing from the 1970s, the current testing with the NMR testing and the CAC testing, is that the thing that is driving atherosclerotic plaque are the small, dense LDL particles, okay, oxidized by insulin, not the large, fluffy LDL particles that are healthy, carrying the healthy cholesterol, which is necessary for tissue repair and hormone synthesis to your body. And it's probably time that we stop vilifying cholesterol as bad. It does so many good things around the body. It's like trying to blame the firefighters for starting the fires. We have associational studies of every time we have buildings on fire, firefighters are there, therefore the firefighters must be starting the fires. Okay, so the totality of available evidence does not support further limiting the intake of such foods. The Academy of Nutrition and Dietetics issued a statement that said saturated fat should no longer be considered a nutrient of concern based on the lack of evidence connecting it to heart disease. One of the last studies I'll show you comes from British Medical Journal 2019. The preponderance of evidence indicates that low-fat diets that reduce serum cholesterol do not reduce cardiovascular events or mortality. These conclusions stand in contrast to current opinion. That's a very nice way of saying there's a lot of disagreement to that, but this is the facts. Here, I think this is my last study, the 2019 study, a meta-analysis study, effects of carbohydrate-restricted diets on low-density lipoprotein cholesterol, this is LDL, in overweight and obese adults, a systemic review and meta-analysis. Okay, so basically they took a whole bunch of people. I think they had 8 randomized controlled trials. They had, let's see, over 1,000 people in this study, and they looked at people who were on low-carb, high-fat diet versus high-carb, low-fat diets. So it's kind of like a shootout in the OK Corral of which diet's better. And so the bottom line is that if you restrict carbs, you're going to do better in a lot of areas. The thing about this is that when you put people on a high-fat diet or a low-carb, high-fat diet, in other words, the fat that you eat in the diet will make your LDL cholesterol go up, or your LDL-C and total cholesterol go up. And this debate has been going on for, decades, And when people are on, doctors have been telling people don't eat a lot of fat, and because of that, they eat more carbs. They eat more fruits and vegetables that have a lot of carbs in them, and they don't eat fat. And when that happens, yes, your LDL cholesterol goes down, but it makes people hyperinsulinemic. It can because of the high carb. So we're kind of looking at this tension here between if you're eating healthy fats and low carb, you're keeping your insulin low. You will see a bump up in the LDL cholesterol, the LDL-C and the cholesterol. But again, the point of this study is that that's not a problem. That's not a harmful situation. Okay? So large randomized controlled trials of at least 6 months duration with carbohydrate restrictions appears superior in improving lipid markers when compared with low-fat diets. Okay? So the dietary guidelines should consider carbohydrate restriction as an alternative dietary strategy for the prevention or management of the dyslipidemic patient populations with cardiometabolic risk. That's the bottom line. And when you look at this was randomized controlled trials, 46 studies here were represented, 5,612 people in the study, and then they did a meta-analysis of 64 studies. And all of these were all the studies that were listed, and these were the variables of weight, HDL cholesterol, triglycerides, blood pressure, A1C, fasting glucose, fasting insulin, C-reactive protein, which is an inflammatory marker, insulin sensitivity, waist circumference, total cholesterol HDL ratio, total cholesterol, and LDL. Okay? So all of these things are the things that we as doctors measure all the time. But the LC means low carb diet, LF means low fat diet. So the low-carb diet's all blue, the low-fat diet's all red. And the square shows that which one was superior. So all of these studies show, in terms of weight reduction, low carb all the way. Why? Because insulin's a fat storage hormone, right? The low carb diet preserves the LDL, right? Because you're reducing insulin, and insulin's not creating that state where HDL is having to work so hard. Triglycerides, same thing. Blood pressure, same thing. A1C, same thing. Almost in every parameter. The only two parameters where the low-fat diet wins is it is superior in terms of total cholesterol and LDL. And this is what every single controversy is. The people that are chasing LDL cholesterol claim all this all the time. But again, we're making the point here that LDL cholesterol is not the predictor as powerful as total cholesterol HDL, or in another case, triglyceride HDL. And so they outperform all these metabolic risk factors. So I would say use your risk ratios. I personally use triglyceride HDL. They have a higher predictive value. And the studies now are coming in to saying it's okay to tell your patient to eat a low carbohydrate diet because they will have some healthy fat, more healthy fat in it. And it is, although you may see a little bit of bump in the total cholesterol and LDL, that's not something to worry about. Cholesterol is a good molecule, and LDL is a lipoprotein. And those are just part of this great energy cycle that the body has going. So a great movie that you could talk to your patients about looking at, I use this almost every day, is Fat Fiction. It's free on Amazon Prime. I think if you want to buy it, it's only like $9. But it's great. It's a couple hours long, and it really goes into some great educational topics, especially about nutrition, diet, obesity, diabetes, hyperinsulinemia, and things you can do to try to improve your metabolic health. I hope this was helpful to you, and thank you so much.